I'm Dr. Ted Lyons from Winnipeg, Manitoba, Canada. I'm going to be talking today about postpartum bleeding and focus on some of the things that are of concern and may be difficult in the clinical situation, such as retained products or even AV malformations. I have no commercial associations, and most of the photographs have actually been taken myself, so I give myself permission to use these. Late postpartum hemorrhage, either from spontaneous vaginal delivery, therapeutic abortion, or spontaneous abortion. Is there a normal amount and duration? Yes, there is. There's a gradual decrease in flow and change in color from red to watery pink, and it may last up to 2 to 3 weeks, but it's abnormal if anything lasts more than 2 weeks postpartum. If there's persistent bleeding, or even if there's stop and then start several weeks later, those are all abnormal. So what are the causes of postpartum bleeding? Well, continuous bleeding may be due to a failure of the endometrium from which the placenta came, the failure of the endometrium to regenerate, or subinvolution. You can also obviously have retained products. In a start and stop situation, endometritis, inflammation, or an invasive mole, gestational trophoblast disease, and also AV fistula or AV malformation. But you have to watch out for that, and we'll talk about that later. Well, why is it important to get the exact cause of the bleeding correct? Well, obviously, it's important because there are different treatment options with each one. So delayed endometrial regeneration, you don't do anything. You wouldn't go in and do a D&C on something where there is a normal placental bed, but it just hasn't regenerated quickly enough. Retained products, obviously, with tissue in there, you're going to want to remove it, so a D&C. Endometritis is inflammation, and antibiotics are important. An invasive mole, hydatidiform mole, needs methotrexate. And finally, the AV fistula or malformation, which may be traumatic or post-traumatic, angiography is very good to assist in the diagnosis and also in the treatment with embolization. Or you may just simply want to watch it. Bottom line is you've got to treat the patient, not just the image. In unexplained postpartum vaginal bleeding, it's really important to use color and to use spectral to see where there is flow and to track the velocities. Very high velocities are of concern. Delayed regeneration of the endometrium. Here we have a coronal view of a uterus, and there's a spot that I have identified that was where the placenta implanted, and there's bleeding from it. So it presents with persistent bleeding, probably due to subinvolution. The endometrial bed, the endometrial defect that was the placental bed has not yet re-epithelialized and has not gone back to its normal state. So the endometrium and decidual basalis have not regenerated the placental site. Usually, as you would expect, the ultrasound is negative. You don't see a mass, and there's no increased color velocity. Obviously, conservative therapy. There's nothing to do other than to wait and see. Obviously, a D&C is not only not necessary, but would even be counterproductive. So a typical case might look like this. Nice normal uterus, anteverted, nice endometrial canal, normal endometrium, and the myometrium. Retained products of conception. It usually presents with persistent bleeding, and here I've drawn a retained cotyledon from the placenta. Well, in a complete abortion, clinically, there is no bleeding. Ultrasound, no mass, endometrial fluid, or increased vascularity, and the uterus is non-tender. So here's a nice case of a complete abortion. She did have a gestational sac at 6 weeks. Now it's all gone. Now there's normal vascularity. So there's no retained products. But how would that compare to a situation where there is retained products? So here's a patient who is bleeding at 11 weeks menstrual age. She was passing clots. You look in the endometrial canal, and there's normal vascularity. So it's a thin stripe, no significant increased vascularity. Empty uterus, no increased vessels. Again, another complete abortion from a early pregnancy that we had seen 2 weeks prior, a nice normal 8-week pregnancy that aborted spontaneously. So in retained products, what are the findings? Well, clinically, they almost always have bleeding, and they may well be passing some tissue. The ultrasound examination within the endometrial canal, you can have a wide endometrial stripe, you can have a mass, or you may see nothing at all. Color and spectral is critical. You may see a single or a group of vessels and usually have high velocity flow. It can actually be very striking how high the flow velocity is, and it may generate a lot of concern, but remember, it's usually a normal finding to have high velocity flow in retained products. The uterus is non-tender on pelvic examination. We always look for tender uterus or tender adnexa that might give us a clue to what the actual patient's problem is. Not everybody does this, but I think it's very, very important. In cases with endometritis, pain and a tender uterus is very, very important. So if you have retained products and you also have some infection that can happen, you have vaginal bleeding that may be persistent, you often have an echogenic mass in the canal, remember it can be retained products or it can just simply be a hematoma, and they may be difficult to differentiate, although the hematoma will not have any internal vascularity. You will have focal increased vascularity in retained products, obviously, but not in hematoma. If there is infection as well, pain and tenderness will give you the indication of endometritis. If you don't push on the uterus and ask the question, does this hurt? Then patients will not be able to tell you that it's tender, and you will miss the diagnosis of associated endometritis. So it's very important to ask the question, does this hurt, when you're pushing on the uterus or the adnexa? So here's a case, a patient who has bleeding. You can see there in the central endometrial canal a mass measuring about 17 millimeters in diameter with increased vascularity. The uterus was non-tender, so you have bleeding, you have a mass, you have vascularity in a non-tender uterus. This woman was 3 weeks postpartum, passing clots. She has retained products, and the treatment is a D&C. A woman who had a therapeutic abortion at 5 weeks menstrual age, gushing blood, has this large echogenic mass identified by the arrows. She had retained products at pathology, and you can see on the color Doppler that there's tremendous increased vascularity in that mass. So the mass, the increased vascularity, and the clinical situation of a patient who is bleeding following a therapeutic abortion are all indicative of retained products, and that's what it was. I mention this specifically because many centers use just 2D ultrasound and don't always use endovaginal, and endovaginal is critically important, but also is color and also is identifying focal areas of tenderness. Another patient, 3 weeks after a spontaneous vaginal delivery, had an area of increased echogenicity, tremendous increased vascularity, so obviously we're thinking about retained products. And here on a video, you can see the area of increased vascularity in the fundus, an area that is common to have retained products. And when you do the spectral, you can see high velocity flow over 100 centimeters per second and even up to 160 centimeters per second. So retained products. A woman who had a therapeutic abortion 6 weeks ago, continuous bleeding, does she have retained products? You look at this scan and you say, well, I'm not sure if there's anything going on, but look carefully. There is an area of increased echogenicity in the myometrium anteriorly, and there was increased vascularity and high velocity flow. So whereas the 2D image was perhaps a little bit subtle, the color turns you on to the fact that she has retained products. And in fact, at DNC, they had retained products. So retained products has a variety of appearances. Here's another patient, 30 weeks. She's 4 weeks postpartum, post-cesarean section, with bleeding and a very subtle mass. So here you see this beautiful triangular shaped defect, typical of a previous cesarean section. You may not have really appreciated this echogenic mass up in the fundus. Here it is highlighted, but that echogenic mass was retained products. You turn on color, you have an area of increased echogenicity, and at DNC this was retained products. So she had a mass, pain, a mass, bleeding, and increased vascularity. Sometimes it's very difficult. This 35-year-old woman has been bleeding for 2 weeks after a spontaneous abortion at 19 weeks. Does she have retained products? That's usually the question that they ask. Does she have retained products? You look at that, and the uterus is certainly bulky. The endometrial canal looks empty, but what about this area? It is heterogeneous. Is this an area of retained products? She actually had an area of increased vascularity right in that subtle area. So we suspected that she did have some retained products there. Again, more based on the area of increased vascularity. And this, in fact, at DNC was proven to be retained product. So there's a wide variety of appearances of retained products. Here's a patient who had a therapeutic abortion 6 weeks ago. She had at the time a 5-centimeter corpus luteum cyst, and it was felt to be useful to follow up the cyst. She's on day 5 of a rather heavier than normal period. Other than that, she's had no symptoms. Sonographically, on sagittal view, you see nice endometrial canal. Transverse view, similar. Nice endometrial canal, nice myometrium. Nothing really exciting. But you turn on the color. And here you see, again, an area of increased vascularity extending down to the endometrial canal. And there was some increased vascularity. So this patient actually had a DNC and had a small area of retained products. I suspect this is far more common than we actually see, small areas of retained products. And is treatment always necessary, or will these actually resolve spontaneously? So to treat or not to treat, that's the question. Most gynecologists treat the symptoms. You don't treat the images, you treat the patient, you treat the symptoms. If there are ultrasound findings of retained products but no bleeding, do you watch and wait? Most will. Except if there is a large mass and signs of myometrial invasion, and that should be monitored closely on ultrasound. And obviously, if you have tenderness, signs of infection, uterine tenderness, they're going to want to give antibiotics. You're never going to know if that uterus is tender unless you say the words while you're pushing on the uterus, does this hurt? Is it tender? Here's a wonderful example. 35-year-old girl at 15 weeks, bleeding. Is this an incomplete abortion? Is there retained products after an abortion? She has an area of increased, an area increased in, she has tissue, or she has echogenic material within the endometrial canal that has no vascularity. So is this an incomplete abortion with products of conception in the lower uterine segment, or could this just simply be a blood clot? Again, treat the patient. She was bleeding. They did a D&C. This is a very interesting patient. She was absolutely asymptomatic 3.5 months postpartum. Maybe she had a little bit of spotting, or else she wouldn't have come to ultrasound. We saw this large mass, echogenic mass with no increased vascularity, situated right in the endometrial canal. When I called the doctor and I said, there's something going on in there, she was absolutely amazed. She said, are you sure? Because this woman is absolutely asymptomatic. No, I said, there's definitely tissue there. She said, well, okay. They did a D&C, and there was retained products. Most unusual in a woman with very, very little symptoms for such a large mass lesion. She had, again, the mass, but really very little bleeding, not a lot of increased vascularity, and non-tender, but she did have retained products. Another patient, 9 weeks post-cesarean section with bleeding, passed clots 2 days ago. Well, you do the scan. Endometrial canal is not bad, no real increased vascularity. So it looks pretty normal. And in this patient, you may well want to just simply, again, treat the patient. She's not having a lot of symptoms other than some bleeding. She may well be treated, and was treated, conservatively. A 29-year-old patient, 12 weeks, but no bleeding. She has passed clots, but there's no bleeding right now. She has a wide endometrial stripe and some increased vascularity. She was pregnant. Here is a 5-week pregnancy. She had a therapeutic abortion. And the question is, what do you do? Well, this was her again with a large empty gestational sac. So on the sequence of events, she had an early pregnancy with the large yolk sac. Now she has a failed intrauterine pregnancy, and so you're going to want to monitor it. She actually passed the sac. Here is where the implantation was, where that increased vascularity, and here you see that area of retained products is where the implantation site was originally. So there's good correlation. She had retained products. She doesn't have any bleeding now, so how are you going to actually treat this patient? I think that this, and here you can see the vascularity on the cine. You can see the increased vascularity on the posterior wall, which was the site of the retained products. This particular patient, they watched her She had no clots in the last 7 days. The endometrial stripe is now thinner. The question is, was there any increased vascularity? And in fact, there was some persistent increased vascularity. And she had some retained products, no mass, just the vessel only. 1 week later, no vessel. So was this really increased? Was this really retained products? Or can you just see a persistent vessel that may in fact resolve on its own? And do you always need treatment? So regardless of what the ultrasound may show, you got to treat the patient. And so she had conservative treatment with resolution 2 weeks later. Another patient, 12 weeks, menstrual age, bleeding, past a fetus. Does she have retained products? So she has a widened endometrial stripe with no increased vascularity. She had a D&C the next day. They had decidual only, but no evidence of retained products. So she had the D&C because she was bleeding, but we didn't see any increased vascularity here. A woman who was 22 years old, had a therapeutic abortion at 9 weeks, some bleeding that has now decreasing, so does she have any retained products? So she has a widened endometrial stripe, she has some echogenic material, no increased vascularity. How are you actually going to treat this patient? She has no bleeding, she has maybe a little bit of a mass and no vascularity. And so you may well want to treat this patient conservatively. Retained products and endometritis. You have to do an endovaginal exam in order to assess uterine tenderness, and you have to ask the patient, does this hurt? So here's a patient 2 weeks postpartum. She has pain and bleeding. So here on ultrasound, you can see the echogenic mass, you can see all kinds of increased vascularity, and she has a tender uterus. She has little bits of air in the endometrial canal that you may or may not see. But the uterus was tender, so she has retained placenta, retained products, and she has endometritis. And here, and then following a D&C, she had a D&C, and following a D&C, she had that mass removed with only a small amount of fluid in the endometrial canal. Endometritis with retained products or without retained products. 4 days post-therapeutic abortion, fever and increased white count. Obviously, if patients have all of the clinical signs of infection, maybe they're passing some foul-smelling fluid, they have a fever, they have increased white count, there's no question that they have an infection somewhere. And if they've had a recent instrumentation in the uterus, that's the area that you're going to look at. And she has retained products, and she has a tender uterus. Here you can see tender. She has a tender uterus, so she has retained products as well as endometritis. A 20-year-old who had a therapeutic abortion 5 weeks ago. She's bleeding despite antibiotics. Some physicians, if a woman comes in following a therapeutic abortion and has very minimal symptoms, but has some uterine tenderness, and you can see the uterus was tender on ultrasound, they may just give them antibiotics in the office and not, in fact, do an ultrasound examination. So here they did the ultrasound. Is there any abnormality? Well, there may be a small area of increased tissue with some increased vascularity. This could be a small area of retained products, but a tender uterus. So she had a D&C to remove this area of retained products, and she had antibiotics to cover the infection. Endometritis only may appear with spotting or bleeding weeks after delivery. The scan is often done to rule out retained products. They may have minimal discharge or minimal fever. Ultrasound findings may be normal. There may be some endometrial fluid, maybe some air occasionally, and uterine tenderness on endovaginal examination. And obviously, the treatment for endometritis only is antibiotics and not a D&C. Here's a patient who had a therapeutic abortion at 16 weeks. 5 weeks later, she's got some bleeding, fever, foul-smelling discharge, no history of pelvic inflammatory disease. The uterus looks fine, no retained products, but the uterus was tender to palpation. She has endometritis, and she would be treated with antibiotics only. A patient 3 weeks postpartum, recurrent fever, pain, manual removal of the placenta. That's a key. Someone put their hand in there in order to treat the patient at the time for a placenta that was overly adherent, so they may well introduce infection into the uterus. She has some free fluid in the endometrial canal, echogenic areas consistent with air, so she had, and a tender uterus, so she had retained products. Here's a patient 5 days after a cesarean section, has fever, so obviously there's some infection somewhere. This is a view of the lower uterine segment. Here we're looking at the cesarean section scar, but it actually has a hematoma within it. It has a mass, and it has areas of increased echogenicity consistent with air. So she has an infected cesarean section hematoma. Another patient, and this is a real dilemma. This is a patient who has, she had a therapeutic abortion, and now she comes back with some bleeding. You see areas of significant increased vascularity with high velocity flow. And the question is this just simply retained products? So high velocity vascularity, retained products, is very common. Remember, there are AV fistulas within this adherent placental tissue, so they're common in retained products. You can successfully treat it with the D&C and seldom have excess blood loss. But when you're looking at the myometrium, one of the things that you should look at, not always there, but one of the things you should look at is, are there any large myometrial holes that may have high or even low velocity flow? A large AV fistula, and this is different than retained products because there's a tremendous amount of flow, has usually large holes in the myometrium, large vessels, and excess bleeding. And in fact, one of the concerns is that they can exsanguinate. So, causes of bleeding. AV fistula or malformation, remember, it can still be retained products. Gestational trophoblastic disease, what is the difference? With an AV fistula, people will bleed like stink. You're gushing blood. The beta may well be negative. High velocity flow, large holes in the myometrium, and treatment. You may have to do compression with an intrauterine catheter. You may want to embolize, or you then may want to wait, and some of these people may actually require hysterectomy. With gestational trophoblastic disease or a mole, you have moderate bleeding. The beta-HCG is going to be positive. The vascularity that you see has low velocity rather than high velocity. You may actually have large holes in the myometrium and a mass of vessels, but you're going to treat it mostly with methotrexate. you may also require a D&C. So here you have a patient bleeding 6 weeks after a therapeutic abortion. Question was there retained products? Here you can see a mass of tissue. In this particular patient, an article had recently come out about AV fistulas, and so we were keen on looking at the vascularity. And you can see these corkscrew vessels, high velocity flow. We were concerned that this patient actually may have an AV fistula, not just retained products. So we talked the radiologists into doing an angiogram, and they saw areas of rapid filling of venous flow as well as arterial flow. And they said, yes, there is some AV fistulas there. The seasoned angiographer said, no, she's a young girl, I'm not going to do any embolization. I'd have to embolize too much, and I don't want to affect her potential fertility. So he did nothing. I wondered what became of that woman, and 6 months later I called her back for a repeat ultrasound. I said, whatever happened after you had the angiography? She said, well, nobody treated me, the bleeding stopped, and 6 months later, obviously, she had nothing serious, and now she's pregnant again. So it's clear that what the seasoned angiographer did is just give this woman a tincture of time, watch her treated conservatively, and not do any angiography was the right treatment. So now you look at a patient who has huge volume and extent of flow, 26 years old, has had numerous pregnancies, and now you see a uterus that has these big holes in it. It looks abnormal. These big myometrial holes and some fluid in the endometrial canal. Whatever this is, this can't be normal. So this we were really quite concerned about. We brought her, we turned on the color, and here she has flow, extensive flow throughout this myometrium. This is definitely abnormal, and she did have increased flow. So the flow was not that high, but it was definitely abnormal for sure. So now what are we going to do? Here in power Doppler, again, shows the massive amount of flow in the uterus. So she needs an angiogram, and they did an angiogram on her. And you can see that as soon as they put contrast into the left uterine artery, she's almost immediately getting huge amount of venous flow. So she's got a large AV fistula in that uterus, and that's what's causing all of the ultrasound findings. They also had increased flow in the ovarian artery as well. So what they then did was, here you can see the right ovarian artery. That also has significant increased flow. So this patient needs surgery. Post-angiography, they embolize the uterine and right ovarian arteries in order to control the flow prior to surgery. And here you can see some of the coils that were put in. They then took her to surgery. So here you can see the uterus and the right ovary, the enlarged right ovary. Here you can see the uterus and the left ovary and the large right ovary, normal left ovary and enlarged right ovary. They removed the uterus uneventfully, and the uterus looks not too bad. When you open it up, you can see these large vessels that obviously, because the pressure from the arterial system has been removed, the vessels are much less dramatic. But this patient had AV fistulas that could have been disastrous for her. Another patient, she delivered at 21 weeks, manual removal of the placenta, and she has, again, tremendous area of increased vascularity and sort of small holes in the myometrium. Is this an AV fistula? Is this something that we have to be really concerned about? She had tremendous amount of vascularity seen associated with this, with these holes and with the mass in the endometrial canal. So she had large vessels, increased velocity. What are you going to do? Does she also need a hysterectomy? She's only 22 years old, and she's just delivered a baby. Well, the patient went to the ward after ultrasound. She had uncontrollable bleeding, so now you're wondering about AV fistula. The interventional radiologist would not embolize, and so the obstetrician put in an intrauterine balloon, really just a Foley catheter. The balloon stopped the bleeding, compression. It stopped the bleeding, and 24 hours later it was removed. She had no bleeding, and she was sent home. 2 weeks after what looked like a disastrous situation, the uterus looks normal. So they had compressed and stopped the massive amount of flow in this woman, and so just with conservative management and balloon compression, she actually retained her uterus and everything was fine. So AV fistulas versus retained products. Don't overcall AV fistulas because the results can be disastrous. AV fistulas should have large myometrial holes, but not always. And there's a large overlap between AV fistulas and retained products of conception. Here is a patient 5 weeks postpartum, had heavy bleeding and clots. Again, is this retained product or AV fistula? She decided just simply to leave home, to leave the hospital. She did have some increased vascularity, but we're seeing a lot of things that it's not absolutely always clear. She had an area of increased vascularity, she left, and she came back fine. So was this retained product, or was this just simply, could this have been an AV fistula? Now here's an area that's much more concerned. Enlarged uterus, thickened myometrium, a bunch of holes in a woman who has a high beta HCG. High beta HCG. So now we're not thinking of retained products, but what we should be thinking of, hydatidiform mole. And here, when you look at the vascularity, it's low vascularity. So high beta HCG, low vascularity, we're thinking now hydatidiform mole, and that's in fact what it was. You look at this and it looks, well, there's a mass and increased vascularity in a woman who had a therapeutic abortion 6 weeks ago, has been bleeding for 6 weeks, has a positive beta. I might just simply have called this retained products had it not been for the positive beta. But remember, the beta can continue to be positive after delivery and gradually dropping. Hers was not dropping. The mass, the low velocity flow, she actually also had an invasive mole. It looks different than the previous case. So again, there's a wide variety of these. Trophoblastic invasion of the myometrium. What's the significance? May need surgery, but can resolve spontaneously. A woman with bleeding 6 weeks post-spontaneous vaginal delivery, manual removal of the placenta. You look and you see a big mass there. You have to look closely because the mass seems to extend into the myometrium. And when you look closely, there it is going almost to the serosal surface. So the question is this retained products? But more importantly, is there an area of placenta increta? When you look back at the 7-week scan, you can see that the placenta was extending right into the myometrium. She has an area of placenta increta. She had had enough pregnancies. They were quite concerned about her, and they decided to do a hysterectomy. Here's the unbisected uterus, and here you can see the bisected uterus with that trophoblast extending right out to the serosal surface. So this was a mass of invasive trophoblastic tissue. Obviously, a hysterectomy was the correct case, was the correct treatment in this case. Another patient, early pregnancy failure, 29 weeks, untreated, myometrial invasion. So here we look at this case and we see the non-gravid uterus. Here then she gets pregnant. It looks not too bad. You can see the gestational sac. She's had some bleeding at 8 weeks. She doesn't want a D&C, so we're managing it expectantly. Normal placental implantation site anteriorly. We keep following her now a week later, and she has a prominent vessel extending right into the myometrium, and you can see it on 3D. Prominent vascularity in the anterior myometrium. So what is this? Is this retained products? And she has, again, high velocity flow. And is there anything we need to do about it? Well, if you look again at the 2D, you can see this heterogeneous trophoblast extending into the myometrium. Does this patient need a hysterectomy? This was 1 week apart. She has persistent trophoblasts with increased vascularity, but she's clinically well. So what to do next? Do you monitor her beta? We should monitor her beta. Do you do a D&C? Or do you give methotrexate? Well, they decided to give methotrexate, and a week later, everything is cleared up. So sometimes, and here it looks quite normal, so sometimes just simply watching, we're seeing a lot of things that we weren't seeing before because of the improved equipment, but do you always have to treat the things that you're seeing? Patient who has 10 weeks, early pregnancy failure, an empty gestational sac, and you look at the endometrial canal, and extending into the myometrium is an area of increased echogenicity. It looks like myometrial invasion. There's some increased vascularity in that region. What should you do? Is this molar invasion? Is this trophoblastic invasion? There was some high velocity flow. She's only spotting, so what do you do? Well, this patient, they just simply, again, they treated conservatively and she resolved. At 16 weeks pregnant, this woman has had bleeding for 2 months and finally just came to see a doctor. She has these big holes in the endometrium or myometrium, very, very confusing, and has some high velocity flow. We brought her back a day later because or 2 days later, I wasn't exactly sure what was going on. Sorry, 3 days later. And she had passed whatever it was. And I said, well, it must have been a mole. Did you pass a bunch of grapes? She said, no. She said, I passed a collapsed fetus. So this whole area that is quite distorted, maybe that was the head and the body, I don't know, but this was actually a collapsed fetus. Finally, here you have a patient, again, a similar situation. She had some interventional procedure. Now she's got this big mass in the endometrial canal, but it's avascular. Remember, an avascular mass can simply be a hematoma. She was pregnant earlier, she had a small embryo, she had a therapeutic abortion, and now she has a hematometra. No mass, and in fact, depending on her clinical situation, you may do a D&C. Another patient with a clot, a vascular clot in the endometrial canal, mixed echogenicity, hematometra, or a blood clot, rather than retained products. And the only way you're going to know is by looking at vascularity. So late postpartum bleeding, first of all, it requires a good history. Is this continuous versus stop and start bleeding? Is the uterus tender? The only way you're going to know about uterine tenderness is talk to the patient. When you're scanning with an endovaginal probe and you're touching the uterus, you've got to ask the question, does that hurt? Is the uterus tender? Endovaginal ultrasound is absolutely critical. And remember, use color and use spectral. So examine the uterus, push on it, ask if it's tender, use color always to see if there's increased vascularity, and use spectral to see whether or not this is high velocity flow. Thank you very much. I hope that this talk has been useful for you.
Retained products of conception, and I'm really glad that I get to give this talk because this is something that drives a lot of people crazy, not just radiologists, but the gynecologists and obstetricians as well. And so I get to do how I do it, which might not be how you and your group have decided to do it, but I hope I'm going to leave you with a few pearls that you can go back to discuss with your referring clinicians. So I have no disclosures pertinent to this presentation. And what I'm going to hopefully answer today is how we assess why there might be pain or bleeding postpartum, a discussion of how you should deal with the obstetrician who says, well, I was in there during that C-section, there's no way there's still placenta. If there's lots of flow, how to figure out if it's an RPOC or AVM, and hopefully I'll convince you to get rid of that term AVM when you're dealing postpartum. And then the myometrium's thin in a patient with retained products. How do you tell if it's an accreta, or how do you assess if it's an invasive mole? So frequently we start out with a transabdominal scan. Now if patients have had C-section, they might have a big dressing on their abdomen. And since you're going to probably go to transvaginal anyway, there's no reason to remove that dressing. But we do take images transabdominally just to make sure we're not missing anything large. And you can frequently see heterogeneous contents within the endometrial cavity. And so the question is this blood products or is it retained products? And when you do a vaginal scan, this is a retroflexed uterus, you can see there's heterogeneous material here. We turn on color and you can actually see some of the flow going into this placental tissue. And then clearly it's placental tissue, you're going to measure it. And the measurement, it turns out, is very important because at least in my institution, if it's less than 4 centimeters, they might try and do medical therapy, try and make the blood vessels decrease, and hopefully the patient will pass it on her own. And if it's 4 centimeters or greater, they're definitely going to go in and do a D&C. So we look for a mass in the endometrial cavity. If there's flow, we know it's retained products. If there's no flow, then it could be devascularized retained products or blood clot. But when you see something that looks like placenta, it has placental type calcifications, you can say that it's retained products. What about when there's something small like this? Well, if you look at the endometrial echo in the mid-uterine cavity, and it is within the endometrium itself, that must be retained products. That's not blood clot. Blood clot is going to distend the endometrial cavity. It won't be just on one side like this. So I know, well, maybe she had a polyp before she got pregnant, but since she's recently been pregnant, it's likely retained products. And here's another patient with a small area with a small bit of blood flow here, and even though it's just a small area here, I can be very, very confident that it's most likely retained products. And the reason we want to be very careful about that is that if they decide to go in and do a D&C, you could end up with a complication like this, where they've actually ruptured her uterus. And so frequently they'll go in and they'll do this blind D&C and they'll scrape really hard, and frequently they'll end up doing this. And so we don't want them to do a D&C procedure when it's just a small area of blood products. So size does matter, and if you have this tiny bit of blood flow here and you don't really see much at all, you can just measure this area with abnormal blood flow within the endometrium, and most likely this is a patient who's going to do very well with tincture of time, with or without some kind of medical therapy. So small areas of retained products can be treated with medications. Usually at my institution they use misoprostol. Larger areas like this, we're going to measure in 3 dimensions, and again, that measurement will help them decide how to go after that material. The other thing you want to do is look at the endometrial-myometrial interface, because you expect placenta to extend beyond the endometrial cavity a little bit. And here we can see this is some calcified material within the endometrial cavity extending into the myometrium. But the further it extends into the myometrium, the more likely it is that you're going to suggest that there's placenta accreta. And here you can see the myometrium's very, very thin. And this would not be a normal placenta. This is an invasive placenta. Whether it's an accreta or an increta, we don't really care. But this is a patient who probably will not do well with a D&C, because if they try and scrape this and get the whole thing out, you know they're going to rupture the uterus. There's no way they can get this otherwise. So causes of postpartum bleeding. When a patient comes in and bleeding postpartum, it really matters how long ago was the delivery, because you might have fluid and debris as a normal finding postpartum. In the first 24 hours, uterine atony can be a cause of bleeding. I'm going to discuss more the subinvolution of the placental site, but it's an important thing to keep in your mind as a cause of bleeding. Endometritis, usually the patient will have pain and discharge, maybe have a fever, and then retained products. So retained products is abnormal. The patients will typically present with abnormal bleeding postpartum, pain, and they may or may not have a fever. And part of the problem with retained products is that it can coexist with endometritis, and that's why the fever might be present. So it occurs, retained products, when there's placental or trophoblastic tissue in the uterus after delivery or miscarriage. It's actually most frequently after a first or second trimester delivery or termination of the pregnancy. And if you think about that, it's because normally the uterus is made to deliver the placenta after delivery in the 3rd trimester. But in the 2nd trimester, the placenta is still very invasive at that point in time, and it hasn't let go yet. And that's why you'll frequently end up with retained products. After a term delivery, it makes sense that retained products would be more common after a vaginal delivery than after cesarean, but of course you can get retained products after a C-section. So here's a study looking at 176 women with sonographic findings of retained products, and when they looked at the history, 54% had had spontaneous abortions, 20% vaginal delivery, 18% elective terminations, and 6% C-section. So you can see 6%, that's a pretty high number for C-sections. Retained products in a cesarean patient, in my experience, most likely these have an evidence of an invasive placenta. And so you should definitely think about that, because again, they've been in there, they've had the patient open. Why would some of the placental tissue still be there? Most likely because it's abnormally adherent. So again, you're going to see this very thin myometrium around the area of placenta. So you definitely want to look for placenta accreta there, and there's no reason to do an MR. We can make that diagnosis just fine with ultrasound. What about first trimester retained products? You know, we think about that as incomplete abortion, for example. Some people will use the term incomplete abortion, some people will say retained products. Here's a study looking at 104 women who had a medical abortion at 6 to 9 weeks. 55% had sonographic evidence of retained products at 2 weeks post-medical treatment, and most resolved without any further therapy. So the symptoms weren't correlated with the sonographic findings. So basically, it takes a while for a first trimester miscarriage to resolve. And so using retained products in the first trimester situation is different than when you use that term after a 2nd or 3rd trimester delivery. So term retained products, it's thought to occur in about 1% of term pregnancies, and the main risk factors are failure to progress during delivery, placenta accreta, and an instrument delivery. I also want to take a minute to talk about severe secondary postpartum hemorrhage. And so this is when a patient has already delivered and then she presents later with bleeding. So 24 hours to 6 weeks postpartum, delivery after 22 weeks, that's the definition. And in this particular study, they looked at a big cohort of women over a 9-year period, and they found the incidence of secondary postpartum hemorrhage of 0.23%, 60 out of 26,000 deliveries. Placental retention, so retained products, was the cause in 30% of those. This subinvolution of the placental bed, again, I'm going to get to that in a minute, happened in 13%, and endometritis in 10%. So keep this in mind when people come back with postpartum bleeding. So what is subinvolution of the placental site? Well, I mentioned that the adherence to the uterus is different in the second trimester than in the third trimester. And what the placenta needs to do is to invade the myometrium. That's how it gets the vascularity to the fetus. That's how it is able to deliver oxygen and other nutrients. So you see hypoechoic tortuous vessels along the inner third of the myometrium without any tissue in the endometrial cavity. And this is what a lot of people end up calling an AVM because they don't see a mass in the endometrial cavity. And yet in AVM, I'd like you to think of that as something that the patient has congenitally, all right? And this is something that's normal. It's physiologic, but it's persistent. So we just need to have another term for it so that people understand that it can resolve on its own. So pulsed wave Doppler sonography can show increased peak systolic velocity with a low velocity waveform, and the increased areas of vascularity correlate with placental implantation site, documented pre-delivery. Moving on now to the management, we can do expectant management. That's where you might just give uterotonic agents, such as the misoprostol that I mentioned before, or methylorgonavine. They can do the surgical management with a DNC or vacuum aspiration. And some people are now more frequently using hysteroscopic removal because that can be associated with fewer adhesions post-intervention. And then we want to reserve interventional radiology with uterine artery embolization for those cases that are very, very hypervascular, that we suspect have early draining veins, or those who have severe bleeding. So here's a study by Aya Kamaya in abdominal imaging last year, looking at predictors of clinical management of retained products and looking at expectant versus medical versus surgical management. And they found that when they saw high flow and they just graded their flow qualitatively, that surgery was likely, and when they saw low or no flow, that expectant or medical management was more likely, and this of course makes sense. So one of the questions that we ask when we see retained products, as I mentioned before, is how large is it? 3 dimensions. Quantifying size can affect management. Does it have flow? And if it has flow, would you call it hypervascular or not? And so one of the things that's not clear in the literature is whether you should perform peak systolic velocity, whether you should actually quantify the blood flow. And I would like to have an argument for saying yes. Now, we can't necessarily angle correct, but we can still get a lot of information from looking at that waveform. So why might retained products be hypervascular and mimic an AVM? Well, again, it's because of the persistence of those vascular changes in the spiral arteries that are induced by the trophoplastic invasion during pregnancy. And then you get shunting from the development of AV fistulas within the placenta that are caused by necrosis of the chorionic villi. And another problem that you can have is that prior DNC can actually lead to some of these AV communications in the myometrium. So here's a drawing from the NCBI website showing in early pregnancy the spiral arteries, by the end of the first trimester showing how they might grow, and by the third trimester how very, very large these are. And it makes sense that if you just lop off the placenta here that you might have some abnormal bleeding. And again, we need this for the placental circulation. So when should you mention subinvolution of the placental site? Well, if you see this abnormal vascularity in the myometrium and you don't see a mass in the endometrial cavity. And it's really important to mention this because this can be treated medically. And what we need to know is that some abnormal flow, what we might think about as abnormal flow in the myometrium, is actually a normal postpartum finding. So in this series of 385 patients who had their first 6-week study after pregnancy, 8.3% had enhanced vascularity by color Doppler. In another series of 93 patients, they saw 50% of patients had abnormal vascularity at day 3, and that went down to 3% at 6 weeks postpartum. So again, very, very common to see a lot of vascularity in the myometrium. In this study, highly vascularized retained products, they found that if a peak systolic velocity was greater than 60, it was associated with blood loss and procedure-related complications. But when they actually did the statistical correlation, they couldn't find that. And this is very problematic because this paper has been misquoted to say that highly vascularized retained products doesn't make a difference. Well, they started out with highly vascularized retained products, and then they looked at variations in that and didn't see a difference. But if you look at all retained products, you're going to see more of a spectrum. So here is a patient. You can see great big vessel in the myometrium, lots of blood flow, at least it looks like lots of blood flow. And if you don't look at a scale here, you might think that's a lot of blood flow, but then when you actually look at a scale, you've got a peak systolic velocity that's actually pretty low. This is somebody who's going to do well with the D&C. So just looking at the color qualitatively, I'm afraid doesn't work that well. Here's another patient. This looks very similar, great big vessel, and here we've got a peak systolic velocity that's very, very high, greater than 80. In fact, when we look at this particular patient, we've got a peak systolic velocity of 190, which is really huge, but it's only a small vessel here. And so we're able to qualify that, and this was able to be removed hysteroscopically without a problem. So I've got 1 minute left to talk about placenta accreta, and I already mentioned the thin myometrium. That's when you're going to mention it. When do you suggest invasive trophoblastic disease or molar pregnancy? Basically, we're not very good at this, and so it's a patient who has a bizarre appearance to the retained products with a persistently elevated beta-HCG. And you can see this looks very heterogeneous after a D&C with lots of abnormal blood flow. So invasive mole is, of course, the most common type of persistent trophoblastic neoplasia, and we usually see this incidentally after a D&C. Another case. And one more case, very heterogeneous, very abnormal appearing, and very, very vascular. When do you need a CT or MR? Basically never. I'm not showing you any CT or MR, and I am showing you one angiography where we had high peak systolic velocity, and you can see this early draining vein. These are the patients that might benefit from embolization prior to treatment. So basically, in the first half of pregnancy, elevated risk for retained products, but it can also occur after term delivery and C-section. If it looks like placenta, it probably is placenta. Color Doppler flow increases the likelihood of retained products, but the absence of flow does not exclude this diagnosis. High peak systolic velocity is associated with bleeding at the time of D&C, so don't forget to assess with spectral Doppler. And please avoid the term AVM, but mention retained products with high peak systolic velocity that might benefit from uterine artery embolization. Thank you very much.